Yeah.
Oh, there we go.
All right. So my name is Nicole Lee. I am a Doctor of Athletic Training student at Indiana State University. And today I have Vince here, and he is a PT student there. So I'm going to kind of let Vince introduce himself, and then we'll kind of talk about what we're doing today for this video chat.
All right. So like Nicole said, I'm Vince Sahagun. I'm a first-year student of physical therapy at Indiana State University, and I am great, and I am excited to be here.
Yeah, I'm super excited. So what we're kind of going to be discussing here is interprofessional and collaborative practice. So we're going to kind of talk about what athletic trainers are and what physical therapists are, and we're going to be kind of educating and learning from one another to really discuss the importance of interprofessional and collaborative practice. So I think what we have some questions that I'm going to kind of ask Vince, and then Vince will ask me, and we'll kind of just go back and forth and make this a fluid conversation and hopefully educate one another on our scope of practice and what we do. So Vince, I'll ask you. So I think one of the big questions that I have are kind of what are the roles and responsibilities of physical therapists?
So what a physical therapist will do is that the main thing with physical therapists is they'll diagnose and they'll manage movement dysfunctions.
Okay.
And the whole goal of diagnosing and managing that will be to enhance physical and functional abilities of a particular individual. So we can, like, the main goal is to restore, maintain, promote, wellness and fitness. And the main goal of that is just to improve the quality of life for the patient that comes in to see us. So with physical therapists, we're obviously one, I can say one chain in the entire link that is, the healthcare, and that's, from the patient to optimal health, right? So, depending on the scenario, depending on the setting that a physical therapist is in, they'll have, we can do, if like say post-op, we have post-op patients, we'll have, what's the thing is called prehab, which is where we try and optimize the patient's movement and the functional abilities before a surgery, just so that I think the reasoning behind it, and I'm not too well versed on prehab, but I think the reasoning behind that is just to, maximize their strength and functionality before going into this, before going into surgery, so that afterwards, that the results are, it pretty much, improves the, the effectiveness, there you go, of like the surgery.
Yeah.
So that's what physical therapists would do.
Okay. And I think back, kind of just picking off of what you said, I think prehab might help the outcomes post-surgery, right?
Yep.
Maybe more of outcomes, whether that might be the patient outcomes or clinician-rated outcomes. So
Correct.
we definitely, and I'll discuss more of prehab because we do prehab as well. And so we have just seen with studies that individual or patients that do a pre-rehab usually have better, and I think better can be a weird word, but have better outcomes post-surgery.
Sure.
Awesome. So, and then I guess, so have you ever worked with an athletic trainer before?
So to the extent, I haven't worked with an athletic trainer. I had one volunteer experience at the ISU clinic where I worked with a DAT, and she was really hands-on. I almost had to ask if she was a PT also, because she was doing a lot of like cool like work and like stuff with the client that she was seeing. So I was like, is she a PT? Is she a DAT? It was really cool. So that I've had one experience, and after that I've only really, that's the amount of experience I've had with an athletic trainer.
That's awesome. I love that you had such a positive experience with an athletic trainer so far, and hopefully at the end of this conversation you'll have another positive experience. So I think kind of I'll go off of what our roles and responsibilities of athletic trainers are. So I'm going to kind of give you, there's 6 domains that we can cover. So that's going to be prevention of injuries and illness. Okay, so injuries, but also if they have any illnesses that might predispose them, whether we talk about sickle cell trait or diabetes, things like that. And then doing clinical evaluation and diagnosis, so we can clinically evaluate and diagnose injuries as well. And then doing any immediate care, so any triage care, so activating emergency action protocols, whether we need to C-spine somebody, call an ambulance, kind of things within that nature. And then we do treatment and rehabilitation and reconditioning. So a mixture of strength conditioning, exercise protocols with the preventative rehab aspects that this injury might happen again. And then, you know, doing any kind of organizational and administrative things. So those are going to be kind of our domains, which are very kind of broad. So that's why you might encounter athletic trainers that might focus in on one and not focus in on the other.
Okay.
Okay.
So my question for you then in that regard is, so what's a normal what's a typical, I guess, setting for an athletic trainer? I know that typically what the everyday man and woman would see is the athletic trainer that comes running out to an injured player, you know, on the pitch or on the field. And I'm sure that's probably the extent of which, you know, the everyday person has seen as a athletic trainer. Are there settings outside of the actual playing field that an athletic trainer is present at?
Yes, absolutely. I appreciate and love that question. So I think too, a part of this, right, as being as a DAT student, we're going to talk about this a little bit later. That's kind of why the DAT profession, I feel like, has been created, is to break down some of these misconceptions or misrepresentations of what athletic trainers are, right? Because we might just see them on a field and you don't know. So my goal as I'm going through my DAT is to educate individuals and advocate for athletic training. And yes, absolutely. So I work in the military setting. So I'm a military athletic trainer. I am not in the military. I'm a contractor. And so I work with tactical athletes. I don't like to call them athletes. I call them my patients because they're a patient before they're an athlete first. So again, another misconception that athletic trainers might have is they go, oh, I work with student athletes. And before they are an athlete, I mean, anybody can be an athlete. Who are we to say you're athletic, you're an athlete, or I'm not an athlete, right? So I think changing our terminology a little bit and saying that I work with a patient, I might work with an older population, I might work with a military tactical population, I might work with a secondary school, which is high school athletes. So you have, I kind of have here, so professional sports, you're going to see obviously basketball, football, and then you might have in a rodeo, X Games, WWE, and then you have college and universities from D1 to D3s. Or D4, I can't remember. Secondary school, which can be the high schools. You're starting to see them, especially in Indiana, in even middle schools. So middle schools will have athletic trainers. Physician practices, so a physician might have an athletic trainer that works. We don't really use this word as much anymore, but it's like we call them a physician extender. Performing arts, so dance, things like that. And then the military or industrial, which is going to be more of the ergonomics. So like Amazon they might have a different name for it, which I don't 100% agree with, but they have people that walk through the warehouse and they're the response team, or they do preventative medicine to educate the Amazon employees on like how to go upstairs and things like that, or how to do boxes so you don't get these overuse injuries that I'm sure you might even see within your setting. So I guess picking off that, what physical therapy settings are there?
So so first and foremost, what's the most visual setting out there is like the ATIs and the Athleticals of the world, like the corporate physical therapy clinics. That is just one obviously very well known setting that would be an outpatient orthopedic setting. But you'll see physical therapists, and you'll see them in nursing homes, hospitals. They have their own private practice, which is where a physical therapist opens up their own. It's kind of the name. It's their own private practice. You know, they have their own building where they obviously have to adhere to the standards and the rules and regulations set by the state, the federal, and the APTA, which is kind of like our occupational body, I guess, so to speak. They can participate in home health, where they'll actually go to a patient's home and they'll do treatment there at an environment that's familiar with the patient, which obviously has its pros and cons, but that's one place where they will go to the patient's home. There's sports and fitness facilities, like there's one of my personal favorites, because I've been following him for a couple of years, is there's a physical therapist named Mike Reinold who's out in Boston, and he has a sports and performance clinic, but he also is a physical therapist as well. So they'll have strength and conditioning coaches, and then that's actually kind of really practical, and it's great in this sense because they'll come in for physical therapy, and then once they get discharged from PT, then they can pass them on, or they can refer them to one of these like trainers at the clinic or at that facility. So that's one place. There's also workplace settings, just like you mentioned. You mentioned with you said industrial, so like with Amazon, there's places like that. They have there's specific programs called like work conditioning or work hardening that can be done by physical therapists in an outpatient setting, but there will be settings where there are PTs like at the workplace. Like actually my girlfriend's work, she works at an office, and it's kind of like a research, pharmaceutical research facility. And then on the main campus, they actually have a gym with a PT on site there. So it's and they're just at that setting. That's where they're practicing. And another place too is that that the PTs can be in nursing homes as well, which actually ties to my first experience, because my first experience in volunteering was when I was 18, and I was following the therapy department at a nursing home, which I didn't know existed.
Yeah. Huh. So it sounds like almost like we have a lot of similar settings that we can work in. I don't really necessarily know if there was one that I can work in that you can't, or I don't know if can't is the right word, but from what I was hearing, it didn't really seem like there was any setting that I could not potentially possibly work in, and vice versa.
Yeah, I feel like there's a lot more overlap than even you and I would know.
Yeah, absolutely. Now let's talk about kind of some degree requirements and professional kind of preparation expectations for physical therapists, and what does kind of a post-professional degree like a DPT, what does that do to enhance your credentials and things like that? Or is that even what you guys need right now? I'm not too sure, actually.
Sure. Yes. So now we do. So now in the United States, the entry level programs for the entry level physical therapy programs are doctorate of physical therapies. Previously, there were MPT, so master in PT, and even before that, it was just a bachelor's in PT. MPTs and DSPTs, they can still treat. Just because they don't have a doctorate doesn't mean that they can't. They've gone through the appropriate continuing education. They've gone through the practice, and there's definitely a check to make sure that they're still practicing to the best of their abilities. So now the entry level is the DPT, is the doctor of physical therapy. In preparing for that, in order to even get into school, a prospective physical therapy student needs to do different types of either work, volunteering, observation at different settings. So like I mentioned earlier, there are PTs in hospitals, nursing homes, outpatient clinics. Depending on the program that you decide to apply to, some programs may require you to, say, have 100 hours, observing or volunteering at a nursing home, or pretty much like an inpatient facility, and 100 hours at an outpatient facility. So for me, I was lucky in that regard, where I was able to volunteer at an SCI TBI facility, and then I was also able to work at 2 different places. So that's what I was doing. On top of that, we need to do, like you and I both had to do, we have to both do GRE, preparation for all that fun stuff involved with the test. And essentially that's it. There's a bunch of like classes that I won't go into too much detail of that we need, like, the sciences, the math, the statistics of the world. We need to be able to go through that. And in regards to that, so once you're actually in school, then you go through school. It's a 3-year program. Depending on the school, depends how they break it up. But most school, or we have another body that's called CAPC, and what they'll do is that they tell the schools, hey, you need to require your students to have X amount of hours, and I believe it's 40 hours, somewhere in that ballpark. And I know that ISU, I may be butchering the numbers, but I know that we do 46 like clinical hours. So we'll go through a year of clinicals, then a year of clinicals, and then at least a year I think more than that of the like classroom work, of didactic schoolwork. Once we're done with that, we have our DPT, but that doesn't mean that we can practice yet. So we have boards that we take, the NPT, the National Physical Therapy Examination, which and the prerequisite is to have your DPT. So you study for boards, you go through boards, assuming that you pass boards, then you become licensed. And then there's another process depending on what state you want to practice in. So we're going to school in Indiana, but if I wanted to practice back home in Illinois, then I have to do a separate, then I have to take Illinois boards. So I technically would not be able to practice in Indiana because I took Illinois state licensure exam, if that makes sense. Like I'd still be a licensed PT, yes, but I would be practicing in Illinois. And after that, right now there's 9 specialties for PT. Like some of them are geriatrics, neuro, sports, women's health, wound management, things like that. And in order to take that exam, so it's another step after becoming a licensed PT, you need to be a practicing PT and you need to have 2,000 hours of experience in that particular area at least. And then you need to pass an examination then, and then at that point, the certification is valid for 10 years. So there's a lot. There's a process involved with getting into school, and then once you're done with school, if you want to do a specialty certification, sorry.
And to do the specialty certification, you don't have to go to a different school. You just have to do so many hours and then take that certification exam.
Correct. Yeah, you would do the hours, and then I would assume that you would have to do some type of special. There's like specific things that you can study like for the examination. I haven't dug too deep into it. The route I'm taking is kind of I'll cross that road when I get there. I want to, I'll get my DPT first and then I'll cross that road. But it's definitely an option for some. I know that I know a fair amount of PTs that have done it, but I also know an equal amount that haven't because they're satisfied and they're good with where they are in terms of being licensed.
That's awesome. So I think I'll talk kind of about athletic training.
Sure. It's
going to be very similar. There's going to be some similarities and some differences.
Sure.
So we have boards too. Ours is called the Board of Certification. You become, and again, this is dependent on each state. So there is I believe it's Texas. I work in California, and we'll talk about California in a second. It's a little bit different. So we have state licensure. That's a little bit different per state, but I would say 98% of the athletic, and don't quote me on that, but a lot of the athletic trainers have taken the Board of Certification exam that allows you to be board certified, and then depending on what state you go to, you have to do a state licensure. Okay. Texas is a little bit different. If they're kind of been grandfathered in, they might not have gone and taken the BOC. They might have gone through a different program and they've made their way. So Texas is like a little bit funky one. And if you have any questions about that, I believe it's Texas. There's a couple other states. I'm just not too familiar with each state act because I don't specifically work there. But mostly everyone has taken the Board of Certification exam, which is actually just a computer exam. It used to be maybe about 15 years ago, you had a computer, or it might have been handwritten actually, like a handwritten exam, and then you actually could do like a physical exam. You had to actually see a patient and do something, but that's since changed. Maybe like PT has, I'm not too sure. So as of right now, starting, so this year, which is 2020, and then next year, 2021, is the last class of bachelor students that can be eligible to take the BOC exam. After that, starting the class of 2022, like if you're going to school in 2022, you're actually going to have a master's. So we are transitioning from bachelor's to, in order to be working as an athletic trainer starting in 2022, you will have to have a master's degree and then you take your BOC. If you've already, like for me, I have my bachelor's, I'm grandfathered in, I don't have to get my master's, if that makes sense. Right. And who knows, they might change it to like, I know a lot of the times a lot of these masters now have like transitional doctor, like DPTs. So that's not 100% yet, that might happen. So we are kind of a little bit behind you guys a little bit, if that makes sense, as into accreditation and like from bachelor's. You guys just went from master's to doctorate, and we're transitioning from bachelor's to master's.
Okay, gotcha.
That kind of makes sense. So, and then after, whether you have your master's, you can actually do kind of more of like a residency, they call it. So you can do neuro. I'm not too familiar on the residencies. And if you have any questions and you want to learn more, there's a couple classmates of mine that have gone through residency programs. I'm still learning about the residency, so I don't feel like that, this would be a great time for interprofessional and intra, so I can talk to all of my colleagues to find out a little bit more about it. But there are residency programs. Like I know Boston has a program. I believe there's a school in Texas that my classmate Dylan went to. And then kind of a doctorate of athletic training. I believe right now there's only 6 or 7 programs. Indiana State is the only CATIE accredited program, which is like the Commission of Athletic Training. So that means if you have to be working, we are clinically working. So in order to be in this program, we have to clinically work at least, I think it's 25 hours a week. So that's why you'll have graduate assistants and things like that. Or like for me, because I have a full-time job, my company that I work for has to sign something.
Sure.
So that's kind of a little bit of a breakdown of hours. And I really, like I was kind of saying about the DAT, at the end of this, so in order to do DAT2, this was actually a question I had for you. So in order to do DAT, you have to already have your athletic training degree. So with PT, right, you don't, like your bachelor degree is not in physical therapy, right? It's in pre-physical therapy. So my question for you is, if you want to go to DPT school, do you have to have, like, can you have your degree in anything as long as you've done the prereqs for school?
Yeah, like the only prerequisite in order to apply for PT school is that you need a bachelor's. It doesn't specify what you got a bachelor's in. A majority of the students that I know, they had a degree in kinesiology. My personal bachelor's was in health sciences, and I had an emphasis in pre-physical therapy because my undergrad had a DPT program, or still has. I don't know why I said had, but I still do. So that's the more common ones. I remember the one that really stood out to me was, I remembered I went on a tour when I was like a sophomore in undergrad, and it was for it was introducing a PT program at a school, and one of the speakers was an acting major. So it was a jump. He was, but when that to me, I was like, okay, that doesn't really make much sense. He was an acting major, but he's a PT. But yeah, as long as you fulfill the prerequisite classes, then you can, and you have your bachelor, as long as you have the prerequisite classes that a specific program requires, and you have a bachelor's in anything at all, then you are able to apply to PT school. So that's why a majority of the students that are in PT school have relatively the same bachelor's, because those are the the requirements in order to get the bachelor's at all. A lot of schools, they'll require like bio, anatomy, chemistry, physics, all that jazz. So obviously somebody that's an acting major, if I had to bet, I would assume that they don't have to take those classes in particular to get their bachelor's in acting or performing arts.
They have to go back. Yeah. So I think that's very similar to how the new applicants that are be going into master's programs will kind of, for athletic training, will kind of be. So like you have, because if you say I got my bachelor's degree in athletic training, and I took my VOC and I passed, I can go get my master's in, I can get it again in athletic training if I'd like, which just to kind of further my horizons, I guess, maybe or less, but I could do it in like sports performance, or I could do it in psychology, sports psychology. So if you already had your bachelor's, you can get your master's in anything. However, now as we're transitioning to this master's program, I believe, and I'm not 100% sure, but like you can have your bachelor's in anything that you would like, and then you would get, as long as you require the prerequisites for the master's program, right? Like you're saying, then you would get into the master's of athletic training. Now for DAT, and this might change, I'm not too sure how the profession will continue, but like for a DAT, you already have to have your athletic training degree.
Okay.
So does that kind of make sense how the DAT is a little bit different than the DPT?
Yeah.
Okay.
So you must already be an ATC, right, to even get into DAT. Yeah.
Yes.
That's the thing with PT is you're either a PT or you're not. You know what I mean?
Yes.
Like there's no prerequisite in regards to the specific occupation. Like anybody can, not, I mean, obviously not anybody, but you can, you know, like I wouldn't be able to apply for DAT, like in that regard. Like,
Exactly.
I don't have an athletic training degree. It's in
Yes.
something else, or I'm not an ATC. Sorry, like I'm not an ATC, so I can't even apply. Whereas Joe Schmo, who has the prerequisites to apply to a PT school, they don't have any certification per se requirement before applying.
Yeah. And so this is kind of, so I think too, that might kind of help clarify too. So like at the end of my DAT, I don't sit for any boards because I already have my boards.
Okay. That's a big difference.
Does that make sense?
Right. That's a big difference.
Yeah. So it's like, because I've already completed it. So then that might kind of lead me into my next question. Well, kind of me meaning like, how does having my DAT, right? Because what does it do to enhance my credential? Because at the end of the day, I don't get a new degree, or I get a new degree,
Right.
but I don't get a new certification, or you know what I mean, like boards.
Right.
So a lot of it, again, as I was kind of saying in the very beginning, is like just breaking down these misconceptions or misperceptions of what athletic training is. And that's really, we want to elevate the practice. I think that going from a bachelor's to a master's is a great, and maybe one day we will be from a master's to a DAT, just like you guys are at right now.
Mm-hmm.
Okay.
So personally, on going off, just to segue off of that, personally, what was your reasoning in trying to pursue a DAT? And two, how do you think personally that a DAT will help you in the future? And what would you say so third question, what would you say to somebody that's thinking about going for a DAT?
Absolutely. So I think right now my reasoning for, the main purpose is advocating for athletic training. I believe athletic trainers are 100% healthcare providers. I think that a big majority of the population does not know that. And I think that comes from, we can point fingers and say this professional doesn't, whatever, but at the end of the day, well, it's me and I have to advocate. So, do I think that change will happen tomorrow? No, but I'm wanting to challenge what we kind of call the status quo of athletic training, so that not the generation right below me that's getting their that's getting their AT degree right now, but the generation below them, those little middle schoolers right now, like by the time that they get to where I'm at, I don't want anybody to ever question that we're not healthcare providers.
Sure.
So for me, it's not about it's a much bigger picture, right? Because then I'm not getting a increase in my salary. Hopefully that would be great, right? But I'm not getting a new degree of some sort. It's just that hopefully I can be a leader so that I can change the profession 10, 15, 20 years from now. So that 20 years from now, a student like me and you are going to be like, oh yeah, well, we're at DAT now. We're at the same level of curriculum and things like that. So, and really elevating to it and changing the idea that we don't work with athletes, we work with patients. And I think that's a big misconception, because they think, oh, well, you only work with athletes. No, I can work in different settings. I can work in, a PT clinic. I can work in anything like that. So hopefully, did that kind of answer your question a little bit?
Yes. Yeah. Definitely helps. Yes. Thank you.
A lot of it definitely comes from like passion and, being passionate about athletic training, and really just trying to educate anyone and everyone on really what athletic trainers do, because I definitely believe there are misperceptions. Absolutely. What are the limits? So what kind of limits are I guess, are there any limits of your job that kind of prompt you to provide kind of collaborative care at all?
Sure. So the first thing that I thought of when I saw that question was I thought immediately of a hospital setting, because in general, the job of physical therapists is to focus more on gross motor function, other functional activities. So we may be providing treatment to somebody, like in an acute care or in a hospital setting. They may be 2 hours post-op, and they may already be having them a physical therapist seeing that individual. However, where physical therapy is kind of limited in that regard is that we're educated in school on fine motor and cognitive function, but there are other professionals like occupational therapists. That's, great example of individuals that they're experts in fine motor, cognitive function, and TTs will educate patients on movements that they can carry over into the real world per se, like shoulder flexion, et cetera. But what the OTs will do is that sometimes they will physically bring them to like a mall or a grocery store and just be with them while they're doing the activity. Like, all right, can you grab that item that's on the high shelf, or can you do this? Can you do that? So OTs definitely in that regard, you can, they work more on fine motor cognitive function, whereas with PTs, that's not our main focus, I guess, so to speak. There can also be speech language pathologists. We're not the most well-versed in the art of linguistics and, bringing back someone's speech when they've suffered some type of, say, neurological injury. We'll be able to treat someone based off of that, but we're more on, in terms of neuro, I've seen more vestibular balance patients as opposed to re-educating someone on how to, articulate themselves properly again. And I think in this regard too, I also thought of ATCs actually, and I also may get this completely off, but to my extent, what I know with ATCs is that they're a healthcare professional that PTs can pass, or that can refer a patient off to once they get discharged, because there comes a point in physical therapy where they won't get the most benefit from us anymore. Like if you got an athlete that wants to work on explosiveness, power, strength, hypertrophy, things like that, we know about that, but from a clinical setting, we can't always be there for them while they do that. You know what I mean? So with I think in that regard, we would refer them to athletic trainers, because athletic trainers, ATCs are in more, I guess, environments where, I said not to use the word athletes, and I'm totally going to use the word athletes.
No, it's okay. That's okay. That's okay.
But
I
you're referring them to. So, I feel like they have a bigger role in the later stages of rehabilitation, for sure, to get a patient back to get to where they need to be. It might not even be a pitcher that had Tommy John surgery. It might just be an individual that's trying to get up and walking again, that wants to implement an exercise program into their lives to help improve their quality of life, improve their function. So in that regard, and so just to wrap up that part where PTs are limited, we have a great emphasis on gross and motor function, but when it comes to fine motor, cognitive function, and the later stages of rehabilitation or just return back to normality, I guess, so to speak, that's where we would refer patients off to the other healthcare professionals in the world.
Gotcha. Okay, cool. Now I'm just gonna ask you a question, and I want to know how much you know.
Go for it.
Do you, let's just case scenario. I am an athlete I'm a patient. I'm an athlete. Okay, let's just say I'm an athlete at a Division I school, and
Sure.
I just tore my ACL.
Uh-huh.
Do I have to get referred to physical therapy, or do you think if I have an athletic trainer at that college that I can work with that athletic trainer throughout their entire rehab?
And so if they so once the injury occurs and they have to get the surgery and all that good stuff, right? Mm-hmm. I would assume that the first couple of days. So I guess just so I can understand your question fully. So yeah, are you asking if the athlete can go straight to an athletic trainer as opposed to somebody else right away?
Yeah, so like, do you think that, like, I guess, do you think that athletic trainers can do post rehab and pre rehab? Do you think that, like, can
Right.
an athletic trainer, I guess, work with a patient from before injury to when injury happens to then they have surgery, like ACL, let's just say ACL? Can I work,
Right.
can an athletic trainer, or do they have to be referred to a physical therapist?
I don't think they have to be referred. Actually, I'm actually not sure. I don't want to give you the wrong answer. That's the
No,
that's
no,
the one
that's
more thing.
okay.
I don't want to give you the wrong answer. I don't think so. I mean, I know that at least at ISU that there are athletes that they go to the PT clinic, but then they also go to athletic training, or they go to the athletic training area. So I'm not sure in that regard. Sorry.
No, and that's okay. And I'm just trying, because I think, again, this is one of these misperceptions. So depending on the state and depending on the specific setting, right? An athletic trainer can do pre-rehab, like you were talking about, and then do all of the post-rehab from 1 day post-op until 9 to 12 months post-ACL.
Sure.
So a lot of and you usually see this more in like the college setting.
Okay.
A lot in the college setting, athletic trainers, and now if they go home for summer, then usually they'll follow up with a physical therapist. But if it's during the school year, that athlete or that patient is actually working with athletic trainer the entire time. So I think when we're kind of talking about how you can transfer, and I love your idea of saying, hey, I think we can transfer care. I just wanted to make sure that and educate you in saying that, you know, we can do post-op protocols. It just depends kind of on your state, if that makes sense. Some states are a little bit different, because I think that is a misperception. Is some physical therapists don't believe that we have been educated in school on how to do post-op protocols.
Gotcha.
But again, that's where I think that collaborative practice comes in. Say if I'm working like right now, especially with this COVID-19, a lot of athletic trainers should be communicating with physical therapists and saying, hey, now that I had care with this, and we're going to talk about access to care in a second, right? Now that I don't have really access to care to my patient anymore, this is what I was doing, and let's transfer, and maybe let's collaborate on this care together, because now you're going to be seeing that athlete or that patient.
Gotcha. Like, so, and I guess bringing it back just a little bit, in regards to limits that, so I talked about a little bit of what limits the job of PTs. So going back to you as an athletic trainer, what are some limits involved with athletic training that would prompt you to work with other healthcare professionals?
Absolutely. So again, this question is kind of a gray area, because it really depends on your state legislation and what your state licensure allows you to do. Because under the BOC, we can do a lot of things, but depending on your state might not allow you to do certain things. So, how
about in California?
For example, so California is a different story. So California is the only state in the United States that does not have licensure.
There's no licensure?
Let me rephrase that. So, anybody in California can call themselves an athletic trainer. So you can be at a sporting event or at a high school, and Joe Schmo's uncle can work the sidelines and be like, oh, I'm an athletic trainer, and you don't have to physically ask for their BOC card. Like, okay, let me see your certification that you took the BOC.
Okay.
Just California. So, and we're working on that really, really, really hard.
Okay. I was going to say that's odd.
Yeah, that's a different story. But a lot of times when you get hired through an agency in California, you still have to show your board certification.
Okay.
That's scary, right? That's like really scary. Like your child could be wherever at an event, and anybody can call themselves an athletic trainer. It's a very scary thought, but we are trying to fix it.
I feel like that's just a whole nother conversation.
That's different.
I can't even imagine that, because holy cow, that's crazy.
Yes.
I didn't know that. So California is different in that regard, to put it lightly.
Yes. And it's not, I mean, don't get me wrong. I mean, imagine if you work so hard for your degree and then somebody could be like, oh, I'm a physical therapist. And you'd be like, no, you're not. But I think
No, you're
even
not.
more
Right.
so than that, it's like the safety of patients. Like,
Yeah.
my ego, okay, it might hurt me, but like at the end of the day, I don't really care if that doesn't hurt me, if that person, you know, it's not about my degree, but it's about the quality of care that I can give patients that somebody that has not gone through my program or that program curriculum could give other patients. And that's the scary part, where they might miss something that could be vital that I have learned that could compromise that patient.
Right.
So I think one thing though, so like, let's talk about, I work a lot. So when I would maybe not transfer, but I would collaborate care. I would, for number one, especially when it comes to, like, let's say concussions. So for California, in California, it's a state law, you have to be cleared by a medical doctor, an MD. So I can say that say somebody sustains a head injury and I'm working the event, I could disqualify them from sport and say, okay, you are showing signs and symptoms of a concussion. And in order for them to get returned to play, or we mostly return to play because it's usually a sport, to get returned back to play, they have to be physically evaluated by a medical doctor.
Okay.
Now there's a whole return to play protocol. So that's really when we would refer to a physician for the most part. We athletic trainers work under the supervision of a physician. Now that doesn't mean they have to be like in our office, but that could be like that we should have access to a physician at all times, whether that be a phone call or things like that.
Gotcha.
So, and then I think collaborating and working with other healthcare providers such as PTs, chiros, acupuncturists, registered dietitians, that's kind of a case-by-case basis, and we absolutely have the ability to do that. I think, although a lot of athletic trainers don't know how to utilize that, and that's kind of where the DAT again comes into place, how I can lead by example and show other athletic trainers that you can use this.
Gotcha. So you mentioned, so a little bit of that too, kind of mentioned a little bit of direct, so kind of, you mentioned a little bit of referring particular patients. So in your example, you use the concussion patient, they need to be referred to their physician. So I guess we'll transition a little bit into talking about direct access for these patients. How would, I can go ahead and go first then and kind of just talk about direct access in physical therapy. So actually, it's really funny that you mentioned that you mentioned a state-by-state basis. That is exactly how it is for direct access and physical therapy as well. So, you know, so in physical therapy, direct access would allow a potential patient to go directly to a PT clinic without a physician referral. However, there's a caveat there. So it depends, like again, depends per state. Some states are unrestricted. With some states there are provisions. And I think with some states you still need, and it's that number is getting lower, but there are still some states where you're required to get a referral from a physician. So in Illinois, so take for example Illinois, because that's where I'm from. So Illinois has their provision. So we need to inform a patient's PCP within 5 days of a first visit, and we need to refer the patient to their physician if there's no measurable or functional improvement after either 10 days or 15 business days, I believe. So that's it for Illinois. In Indiana, that actually just changed last year too, and I forgot the exact numbers for that too. And the thing is too, it depends on direct access. Also, depending on the state, again, it depends what type of treatment that we can do. Like, we can't do imaging. Like in some states, we're unable to do imaging, things like that. Some states are able to do wound debridement. Whereas with so pretty much if a patient comes in and they're a couple days post-op and they need help, getting rid of excess skin, or there's some type of lesion or something of that sort, depending on the state, certain states will allow their physical therapist to work with that wound. Some states won't.
Gotcha.
So the big thing that the PT or that the APTA is trying to advocate for is to have every state allow unrestricted direct access, because the reasoning there is that, well, well, look, we've already standardized the doctorate of physical therapy. So in that regard, the individuals in those programs should be receiving the proper education to be the first person that a patient goes to. And then there's also the main thing that they try and use to advocate as well is that if a patient can go directly to a PT, they may be able to be treated much sooner than if they were have to go to their physician. You know, there's you know, from a practical sense, sometimes they may need to wait until a physician is available to receive a diagnosis, and then there's a referral process. Whereas if they can go straight to the person, then it just speeds up the healing process.
Gotcha. Yeah, that makes sense. Yeah, I think that's gonna be kind of similar to ours. So we, a physician does not have to give a referral for them to see us.
Okay.
So like they, just like you're kind of saying, and again, this is probably per state. So again, a lot of these are going to be state or just like legislation and what you can do in states like that. I think one thing just to I kind of took a little bit of a different take on direct access too, but I think with everything going on right now with this whole COVID, like my patients have really actually gone on to telemedicine. So my direct access to them is not physical encounters, like they're not physically coming in, but we are still providing care via telemedicine and telephone, telemedicine meaning a mixture of virtual, like you and I are Zooming right now. We have a different platform that we use, or phone calls, and still documenting everything and things like that, which I think is great because a lot of people don't know that. They just think they're like, oh, I can't go see athletic training anymore. I'm like, no, we can still do virtual visits and we can do a lot of these things. So I kind of took a little bit, you know, and I'm sure just as PT can do as well. And it's just kind of utilizing telemedicine and incorporating it into your practice. I think the military is a good foundation on that because they've had to use that in the past when individuals are on deployment. They've used it mostly more for like dermatology. So they might have a patient be like, what does this thing look like? You know, they might Skype a doctor type of thing, but now we're starting to utilize it in different ways. So, but again, I think it kind of depends on your state laws. And then we have a couple other questions, so we can we'll be quick with these ones. I know you have to go soon. I have to go soon as well. So I guess what other professions do you typically engage with in your interprofessional collaborative care?
Mainly, again, it depends on the setting, but definitely, obviously, other physical therapists. And I think the professionals that I mentioned earlier, with the ones that we would refer to where our scope is kind of limited, OTs, definitely OTs, speech pathologists, psychiatrists as well. We would work with ATCs. That's pretty common, depending on going back to that sports setting. We would work with ATCs as well. Dietitians, because diet and exercise go hand in hand. So obviously, the effectiveness of the exercise and all the programs that you're prescribing a patient is limited if their diet isn't the best, right? So we would work with dietitians as well. Depending on the situation, like if we have we're in home health, we could possibly work with like a social worker. If we notice that there's an environment that isn't conducive to, honestly, any type of positive, I guess, health, if they're in that type of environment, then we could forward them on to public health and say, hey, I'm treating this patient in home health right now, but there's this and that going on in that environment, and this is something that I can't take care of. Is there someone that you can refer to? So then we'd refer them to public health or a social worker, somebody like that. So there's a lot of people that we would work with on a day by day. It would probably just be the other PTs, and maybe depending on where they are in their recovery, maybe the surgeon or their physician. But there are a lot of professionals that we can engage with. How about for you guys? What about ATCs?
Yeah, I think very, very similar. I think it depends really kind of on your setting. In the military setting, I have really great access to care, meaning like I can put in referrals to a lot of different providers. So, a majority, just like you were saying, whether it be MDs, DOs, like physicians of some sort, mental health mental health can be into psychology, psychiatric care. We registered dietitians. I've worked with a nephrologist before, like if we're talking about more physician-based, occupational therapy, physical therapy, really like anybody. I think that's like, that's weird to say, but I tried to work, in the military. We have also kind of what are called IDCs. So they are corpsmen, and so they might be the quote unquote docs of the ships. So I think, one thing kind of leading into our next question is, kind of how does this affect it? And then what is like maybe the important aspect? I think going off the most important aspect for me that I've seen is communication and documentation, because at least in my setting, my patient might be moving tomorrow. So if I don't accurately document what happened when they go on to, because we all have the same system, like electronic medical system, EMR.
EMR, yep.
Yeah, so if I don't properly document, and I can't talk to a provider because they're on a ship underway, and they don't like the way of documenting, I think, is mostly the most important. And then on top of that, when you do get to communicate with them, like having a respectful and collaborative approach. It's not, you're better than me, or I'm better than you, or this person knows more. It's about, okay, what can you provide for this patient that's going to give them the best care? And what is it that maybe I might be able to provide in a different way, because my education has helped me with this specific region that I can provide, right? So I think, having that approach of saying, your specialty is this, my specialty is this is what I'm seeing on my end, and I think this is how I can help the patient, and this is maybe what I'm lacking, and this is where your expertise is. Please, let's work together to give this patient the best outcome.
Yep, agreed. You pretty much took the words out of my mouth. It just gives from a patient, healthcare professional relationship point of view, it just gives them the chance to know that there are other professionals that are more than qualified to help them in addition to ourselves, and let them know that it's a team effort. It's kind of cliche, but it really is a team effort. If I can't figure something out, I may be going to you and asking, hey, there's some weird diagnoses, there's some weird movement pattern going on. Have you seen this before? And it's something simple as that. And letting the patient know, hey, I wasn't the one that, I got this from somebody else. So definitely, there are other people, not to discredit myself, but there are also other people that are more than qualified to help you as well. Once, where I fall short, there are other people available to help pick me up, and which in turn helps you out as well.
Yeah, absolutely. I 100% agree. I think there have been plenty of times when I've gone to other physical therapists or chiropractors, and that's just like what I immediately have within my office. So, but like the one case where we're going to talk about an instance or a patient where these are where physical therapists and athletic trainers collaborate, but interprofessionally, where I had a patient that was having really bad pitting edema. And I'm like, this does not make sense. You're a healthy individual. And so we got him a referral to nephrology, and he was actually, something was going on. And so it was like, I was physically seeing this patient. I'm like, this just doesn't make sense.
That's not right.
This is not right. And I don't know what's going on. So we got him a referral, and lo and behold, there was something going on with his kidneys and that he was retaining because his kidneys were leaking out fluid kind of. So, it was a case like that where, that kind of interprofessional collaborative communication. And I emailed the provider, and I'm like, I know you're going to be seeing this patient. I'm just letting you know, this is the case. This is what happened. This is what we've been doing. And something just isn't making sense. So, and then again, this is your kind of expertise. Could you run and see what kind of happens? So, and then I think with physical therapists and athletic trainers collaborating together, I think 100%, absolutely. I think there really should not be a time where they say you over me. I think we, depending on, and I think too, letting really the patient kind of not decide, but I'm all about patients like hanging out with different providers. Like, hey, I want you to see me, and I want you to see my other athletic training colleague, and I want you to see Vince, the PT, and I want you to see this patient, and I want you to see everyone, because everyone kind of has their own little niche that maybe they're kind of good at, and maybe that day you need X, Y, and Z. You know what I mean?
Right.
So I really try to encourage that with my patients, where I don't want them to solely see me. If you're at a college level, like you might have an athletic trainer that is only working with this team, so they don't have access to other athletic trainers. But you know, I definitely think that there are definitely instances where physical therapists and athletic trainers can collaborate.
Oh yeah, and I still have a little bit of time too. So if you, I mean, I know you said you had a little time constraint too. How many more minutes do you have, more or less? How much more time do you got?
I probably have I do have a patient here that's getting an X-ray, so I probably have maybe 2 to 3 more minutes. His appointment is at 2, so. Yeah.
No worries. Okay. So all right. So I guess just kind of wrap things up. If we had a patient, so I guess this is more related to the patient that we have in the case that we have. Just in general, without going into nitty-gritty detail, where would you say that I would come into play, and where would you say that you would come into play in regards to treating, who's our patient, Jane?
Jane, yeah, I think, and we can meet and talk about. We'll probably meet again and talk about more of the case. I think this was just we're gonna upload to. For me, and I think this would come down to more of what I'm comfortable with. We are learning about grade 5 mobilizations. I have not utilized them enough, and if there was another provider that I feel had better knowledge, I don't say better knowledge, but had maybe performed it a little bit better, I would probably say and tell the patient, this provider is going to be utilizing this manipulation or this manual therapy technique because they have more experience with it. And just because I'm not because I'm not allowed to do it, I'm just not as comfortable with it as if he would do it. That's kind of what I would say the most part. And if we try to utilize any dry needling, I can do dry needling because of the military. But if, and we can have that discussion for a different day. But if you, I'm kind of newer to it. And so if you've been doing it more, that would be a point where, again, I'm saying, hey, I can do this, but if you have a preference to do this, I'm okay with you doing it.
Gotcha. Well, yeah, I mean, I'd be on the same boat too. Like me as a first year PT student, honestly, I haven't been on the field as much as you have. So you definitely, I feel like you definitely know a lot more in terms of applying the knowledge that you've gotten so far from school. Whereas with me, I'm still trying to figure it out and seeing, all right, what the heck is going on here? What do I do? What's the right thing to approach this, et cetera, et cetera. And honestly, yeah, my approach would be the same as you, because there may be certain techniques that I'm not as confident with, where I would pass them on to you, or I may not know how to optimally improve somebody's coordination or agility. And I feel like that may be one of the many situations where I'd say, hey, go see Nicole. She knows this a heck of a lot more than I would. I'm still learning. She would know it, things like that. So I think that's definitely a good a good spot to kind of wrap it up and put a bow on it, and we'll see what we'll look at stuff and we'll see what what we want to approach for the next meeting.
Yeah, I think that's great. I think we you and I can email back and forth over the next couple of days, and then we'll set up another time before we meet with I believe it's Sarah.
Sure.
So, but yeah, I think this can be a great collaboration. I'm super excited to learn from you, and also just collaborate together to give this patient the best care and the best patient-centered care.
Absolutely.
All right, perfect. So that's awesome. Thank you for taking the time to talk to me, and then we will, I look forward to talking to you soon.
All right, Nicole. All right, take care. All right, thank you.
Yep.